It's Community Pride Day. Perfect moment to talk indirect-acting cholinomimetics. So, what do I mean by indirect-acting? Well, the actions of acetylcholine released from autonomic and somatic motor nerves are terminated by enzymatic hydrolysis, which is accomplished by acetylcholinesterase at cholinergic synapses. While direct-acting cholinergic agents act upon the acetylcholine receptor, indirect-acting cholinomimetics bind either reversibly or irreversibly to acetylcholinesterase, thereby increasing the concentration of acetylcholine at the synapse. Remember our symbol for acetylcholine? That's right, the crisp, cool bottles of acetyl cola, of course. Well, acetylcholinesterase is kind of like this bottle return dumpster here, consuming the acetyl cola bottles that had been strewn about the synapse, stopping their effects. Oh, and watch where you step. This knocked over bottle return dumpster is kind of like the effect of a cholinesterase inhibitor, don't you think? The acetyl cola bottles spilling into the street, reminiscent of how cholinesterase inhibitors increase concentrations of endogenous acetylcholine at the synapse. And yeah, we get it. You're trying to stick it to the man, Tony Hawk style. Do you really have to stick it to the bottle collection, man? Anti-establishment, more like anti-esterase. See the word stigma across the bottom of the skateboard? Sketchy's own foray into skateboard decks. Or maybe a little reminder of the suffix stigmine, which will be incorporated into the names of the cholinesterase inhibitors we're about to cover. But not all the stigmines are alike. There are synthetic quaternary ammonium agents, such as pyridostigmine and neostigmine, which have negligible distribution into the CNS, and we also have a naturally occurring tertiary amine, physostigmine, which, as we'll soon see, has clinically significant CNS penetration. Because cholinesterase inhibitors merely amplify the actions of endogenous acetylcholine, the effects are similar to the direct-acting muscarinic agents that we encountered downtown, including effects on the eye, respiratory tract, GI tract, and urinary tract. However, anticholinesterase agents also increase activation at nicotinic receptors. See this striated skeletal muscle brick wall? While direct-acting muscarinic agonists have no therapeutic value at the nicotinic receptors of the neuromuscular junction, cholinesterase inhibitors can intensify the actions of physiologically released acetylcholine, leading to increased strength of contractions. Let's sketch in an electrical end plate, our recurring symbol for the motor end plate, in order to highlight the important clinical application of cholinesterase inhibitors at the neuromuscular junction. On your exams, the most important clinical use of cholinesterase inhibitors will be for the treatment of myasthenia gravis. Designs on those electrical end plates are pretty interesting, right? Look a lot like gravestones, which, when combined with a motor end plate, is our recurring symbol for myasthenia gravis. Myasthenia gravis is an autoimmune disease in which antibodies are produced against the nicotinic acetylcholine receptors at skeletal muscle neuromuscular junctions, thereby inhibiting their function. Those antibodies that bind the NMJ receptors are kind of like these designs, covering the receptors on the electrical end plates. On your exam, the patient will present with the classic symptoms of skeletal muscle weakness, including ptosis, diplopia, difficulty in swallowing, or proximal limb weakness. Also, the symptoms will be described as progressive, or getting worse with use. And that's where the stigmines come in. Remember that stigma branding on the bottom of the skater's board as she grinds over the overturned dumpster, sending acetyl cola bottles into the street? Cholinesterase inhibitors, such as pyridostigmine and neostigmine, are crucial for getting more acetylcholine into the synaptic cleft, to outcompete those autoantibodies for acetylcholine receptors at the postsynaptic membrane. Long-term therapy for myasthenia gravis is usually accomplished with pyridostigmine. See this giant wind dancer advertising Community Pride Day? Community Pride Day is to emphasize the name pyridostigmine. And just like a cholinesterase inhibitor increasing acetylcholine to wash out those pesky antibodies and activate that nicotinic receptor, our community organizer is plugging our wind dancer into these electrical end plates, activating it for maximum wind dancer movement. Neostigmine is an alternative cholinesterase inhibitor used to treat myasthenia gravis. though not as commonly used. Neostigmine is represented by the neon sign here, also showing that with little extra acetylcholine at the synapse, this striated muscle establishment is now open for business. Remember that these agents provide only symptomatic treatment for myasthenia gravis, while immunosuppressant agents are used to affect the levels of autoantibodies. Notice, too, that the pony ride only accepts quarters. This is to remind you that the cholinesterase inhibitors covered so far, pyridostigmine and neostigmine, contain a charged quaternary ammonium group that makes it hard for them to get into the CNS. Later, we'll cover the tertiary amine compound physostigmine that readily crosses the blood-brain barrier to cause CNS effects. Besides treating myasthenia, cholinesterase inhibitors can also reverse neuromuscular blockade. Neuromuscular blocking agents are used during anesthesia to produce muscle paralysis by interfering with the motor end plate. Non-depolarizing agents, such as vecuronium, tubocurarine, and cisatracurium, competitively inhibit the nicotinic receptors at neuromuscular junctions. These curare-like compounds act like these curare crayons, blocking up the end plate, preventing transmission. Looks like some curious kid is trying to inhibit the cleanup crew around here. After surgery, it's usually desirable to reverse this pharmacologic paralysis. This can easily be accomplished with anticholinesterases such as neostigmine, just like our neon sign store owner who's spraying away this naughty curare kid. Depolarizing neuromuscular blocking agents are a totally different story. See our lollipop-sucking skateboarder grinding along the other motor end plate outlet? This depicts succinylcholine, an agent that causes a depolarizing neuromuscular blockade. Succinylcholine acts like acetylcholine, but doesn't get metabolized as well, so it just sits there, depolarizing your NMJ, causing your muscles to remain depolarized and unresponsive to subsequent impulses. This initial depolarization step is called the phase 1 block of a depolarizing blockade, and, as our phase 1 skateboarder has unfortunately discovered, using cholinesterase inhibitors at this stage will only send more acetylcholine into the synapse and potentiate this depolarizing blockade. Of note, phase 2 of a depolarizing blockade is a little more complex, and cholinesterase inhibitors may be useful in reversing the block at that point. Okay, with all this extra acetylcholine thrown around, remember that cholinesterase inhibitors activate muscarinic receptors as well, causing parasympathomimetic effects, such as pupillary constriction and bowel and bladder activation. In fact, neostigmine can be used to treat postoperative urinary retention and bladder distension, as depicted by this bladder-evoking hose, similar to the one employed by Bethanachol Beth. Let's move across the street. We'll cover our last anticholinesterase agent, physostigmine. The actions of physostigmine will take place in this phys ed center, where we can really get our sweat on. Ooh, final show for the Alice in Wonderland production. Better getting quick. Why Alice in Wonderland, you ask? Well, on an exam, remember that physostigmine can be used to treat atropine overdose. As you'll see in our next sketch, the muscarinic antagonist atropine can cause all kinds of wacky symptoms, making you as mad as a hatter, hot as a hare, blind as a bat, diamond as a queen, all the characters in Alice's Tea Party. Well, atropine Alice here is also accompanied by the belladonna flower to remind you that atropine-related compounds are found in nature, such as in the Atropa belladonna flower or deadly nightshade. This means that an exam question may involve a patient previously working in their garden, moments later presenting to the ER with those classic antimuscarinic symptoms of atropine overdose. Belladonna alkaloids are also found in Jimson weed, hence the weeds, and the word Jim written over the entrance. Jimson weed poisoning is also called gardener's mydriasis, and is strikingly similar to atropine overdose. The muscarinic receptor blockade caused by atropine overdose is competitive in nature, and can be overcome by increasing the amount of endogenous acetylcholine at the synapse. Physostigmine, therefore, reverses these effects, just like this phys ed teacher here covering up that atropine Alice poster. Unlike other cholinesterase inhibitors, physostigmine can enter the CNS, as depicted by the brain bandana worn ever so stylishly by the phys ed teacher. This means that it can reverse the central and peripheral effects of the atropine muscarinic blockade. However, physostigmine itself can produce dangerous central nervous system side effects as well, so sparingly it is used. The toxic effects of cholinesterase inhibitors are similar to those of the direct-acting muscarinic agents. Think of all those parasympathetic effects from the Paracity sketch. In other words, diarrhea, urination, meiosis, bronchospasm, bradycardia, lacrimation, salivation. Patients will also be sweating because sweat glands are activated by muscarinic receptors. The mnemonic dumbbells is used to remember all these moist and sticky muscarinic effects, and we've depicted some of those effects here on this runny, sweaty, and somewhat poopy kid struggling with the dumbbells. Notice that we've also made him too weak to lift them. This brings up an important point. Unlike the direct-acting muscarinic agonists, cholinesterase inhibitors also cause nicotinic receptor activation, as depicted by his nicotine-ridden cigarette. At the neuromuscular junction, nicotinic receptors are overactivated, leading to a flaccid paralysis similar to that depolarizing blockade we discussed earlier. Oh man, you guys smell that? Ooh, no wonder that kid is just about to collapse. Ooh. The major cause of acute cholinergic toxicity is organophosphate poisoning. Organophosphates are cholinesterase inhibitors found in many pesticides used in agriculture and in the home. The word thiol, printed on the insecticide canister, should remind you of the thiosulfate insecticides that often pop up on an exam, such as parathion, malathion, and ecothiopate. These agents can cause slowly or rapidly developing muscarinic and nicotinic symptoms, which can persist for days. Remember that brain bandana as well, because CNS involvement usually follows rapidly, causing cognitive effects and convulsions. The classic scenario involves someone brought into the ER by a coworker because they're unable to continue picking vegetables, or some other farming or gardening activity. And your patient is bradycardic, they're tearing excessively, remember all those runny symptoms, and they can't breathe. What to do? Acute organophosphate toxicity must be recognized immediately. See, organophosphates bind acetylcholinesterase, forming an extremely stable covalent bond. To regenerate the cholinesterase enzyme, an agent called pralidoxime is used. Think of closing the lid on this toxic insecticide, pralidoxime. This agent can hydrolyze that covalent bond and regenerate the cholinesterase at both muscarinic and nicotinic receptors. It's just like this guy here, who's bringing out a new line of bottle return dumpsters. It's important to note that pralidoxime is ineffective in reversing the central effects of organophosphate poisoning because it doesn't enter the CNS. To reverse central muscarinic effects, atropine, a muscarinic antagonist, is administered. See atropine Alice here on the side of the bottle return dumpster? An arrow points inside that psychedelic head of hers because atropine treats the peripheral effects and CNS effects of organophosphate inhibitors. But remember, atropine only reverses muscarinic effects, so it won't reverse the paralysis. Pralidoxime, which regenerates acetylcholinesterase at muscarinic and nicotinic receptors, is your go-to agent to reverse that neuromuscular blockade. Better hurry, though, because pralidoxime is not as helpful if the organophosphate cholinesterase complex has undergone a process called aging. See this old man here who's been spraying pesticide in the city since time began? He represents the aged organophosphate cholinesterase complex, practically irreversible at this point, as you can tell by the gaping, corroded hole in this cholinesterase bottle return dumpster. How long has that guy been spraying that thing? To wrap up our city tour, I want to briefly mention the acetylcholinesterase inhibitors used in the treatment of cognitive dysfunction in patients with Alzheimer's. See this little park across the street? Well, a few of the local residents are throwing a little gala for Alzheimer's awareness. Let the word gala remind you of the drug galantamine, Under it, reverse the stigma represents rivastigmine. And see those two oldies here, still as sharp as a tack? The jigsaw is their jam, because they are done with the puzzle. It represents the drug donepezil. The picture of the brain should remind you that donepezil, rivastigmine, and galantamine are cholinesterase inhibitors that can penetrate the CNS to treat cognitive dysfunction in patients with Alzheimer's, though their benefit is modest. Because of all that extra acetylcholine, these elderly patients can experience some serious side effects, so be careful. All right, now that we've come to the end of our journey through the world of acetylcholinesterase inhibitors, let's allow this proud community to finish setting up for Community Pride Day. Where are you going to find me? The gym? No. The pony ride? First in line. See ya.